I'm a professor of public health at the University of Southampton, and Nisreen, do you want to introduce yourself?
Yeah, Professor of Public Health at the University of Southampton also. But we are talking about a really nice interdisciplinary project. So, over
Yeah,
to you, Simon.
perfect. And we're doing a bit of a double act. I'm just going to share my screen. And if, when I've done that, if someone could just confirm that you can
Yes,
see
it's there,
the
but it's not
screen.
in
Presenter mode.
full mode.
There we
Yeah.
go. That should be okay now. Great, thank you. So in contrast to the last presentation, we're going to present something that's very much a work in progress. So we're going to be talking about MELD-B, and you can see the complicated title there from which that acronym is derived. Essentially, this is a multidisciplinary and multi-center project around a life course approach to multimorbidity prevention, and we're using multiple data sources. It's a complex project. I'm hoping to give you a flavor of it, but as I say, it's very much not a done deal. It's something we're actively working on, and Ashley and Rhiannon are very much involved as well. So the background to this is we're working on the premise that multiple long-term condition multimorbidity commonly develops across the life course. It rarely occurs just at one time. And also we're interested in the fact that people with multimorbidity often experience significant burden. So the challenge of living with multiple conditions is high. Not only that we know, and Jane's talk has illustrated this as well, that multimorbidity occurs earlier in the life course among people from more socioeconomically deprived circumstances, but also some ethnicity groups as well. So the other important thing about this project is taking this life course approach. We are also considering that many wider determinants influence the risk of developing multiple conditions throughout the life course. So your own individual biological, psychological, social, and behavioral development, but also things like your family and parental environment, your education, social networks, economic circumstances, and then wider societal issues as well. And the challenge with looking at the influence of those wider determinants on the risk of developing multiple conditions is that sufficient data on all of those things across that whole life course really just doesn't exist in one source. And we're focusing in this project very much on early life determinants and early life risk factors, and I'm going to let Nisreen explain a bit more about that later. But we're looking at the period from kind of preconception through to adolescence and about sort of age 18. And what we're doing is using multiple data sources. We're using AI. This study is funded as one of the NIHR AIM projects. So AI is an important component. The caveat that I'm going to say early is I personally am not an AI expert, so please don't ask me difficult AI questions. I'll have to refer to my colleagues for that. But we're also using traditional epidemiological causal inference methods. And we're exploring multimorbidity that is early onset, and we've defined that as being by the age of 65. And we're just looking at multimorbidity that is burdensome, and we're having to define that as part of the project, and I'll explain more of that in a minute. So we're using longitudinal birth cohorts, and here are the three that we're using: BCS70, NCDS, and ACOMF. And if you're not familiar with birth cohorts, they're fascinating sources of data. To take BCS70, for example, this is a cohort of people who were all born in the same week in 1970, who have been followed up at regular sweeps every 4 or 5 years since that time. So they're now sort of in their 50s, and collecting extremely rich data on multiple aspects of their lives. As well as those sources, we're using routine electronic health records. Of course, we're using SAIL, and we're also using CPRD to learn something about this whole life course, early onset burdensome multimorbidity. So within SAIL, I'm just going to describe this briefly. We've essentially created 2 cohorts. The first is what we're calling the SAIL MELD-B E cohort. and the second is the Sale MELD-B Children and Young Adults E cohort. And the main cohort is just over 5 million individuals, and followed between January the 1st, 2000 to the end of December 22. So a 22-year cohort study. And the difference with the Children and Young Adults E cohort is that is a subset of that main cohort of people who were born on or after the cohort start date. And just to give you a flavor, and I should acknowledge Roberta, who's produced these graphs on the right, who works on the Sale data. These graphs on the right show, for example, the left-hand one shows the prevalence of the most common conditions in the main MELD-B cohort. I'm not going to go into that in detail, but that just gives you a flavor without giving you all of the detail about the development of that cohort. As you can imagine, it's a complicated thing. But just want to say a bit about understanding this concept of burden from the patient perspective that we're going to be applying in this cohort. So we've done 3 streams of work for this are underway. So we've completed a qualitative literature review where we screened over 30,000 papers and included 46 in our final review of the lived experience of multiple long-term conditions. We're then going to use a consensus study, and we've used extensive patient and public involvement to understand, firstly, what do we mean by burden, and secondly, which aspects of burden can be identified in routine healthcare data, if any. And then what we're trying to do is to characterize that burden in our data, and then undertake clustering around concepts of burden. So which conditions, which combination of conditions cluster around a concept of being burdened. And we're also looking at sequencing, so the accrual of conditions over time towards a burdensome state, if you like. The ultimate goal is to then be able to model prevention, both of the conditions, but also the burdensome state. So being able to look at what could we do early in the life course to prevent the risk or reduce the risk of future multimorbidity, burdensome multimorbidity development. So it's a big ambitious project, and it's very complex. And this is a very complex slide, but I wanted to give you a flavor of what we've called the themes of work. So our patient and public involvement experts tell us that burden is not a term that they favor. They like this work concept. Living with multiple conditions is work. And we have 8 themes. And without explaining them in detail, some of them are those which are perhaps more commonly already represented in the literature. So, for example, medication, polypharmacy, lots of research on that. Similarly, health service and administration, that is part of perhaps the concept of treatment burden. So all the things you have to do in terms of the health service, looking after your health. But we've come up with some other sort of interesting concepts. So as well as symptoms, which are obviously burdensome, emotions seem to be a tremendously important aspect of the concept of burden. And you can already perhaps be thinking, well, how on earth are those represented in routine electronic records? And then accumulation and complexity is this development of how patients might describe it would be, it's one thing after another, doctor. It's just how things develop across life, one thing after another, just building up the burden. Learning and adapting is about the way in which you have to change your life story, how you have to adapt your life to accommodate new conditions and so on. And then the financial burden has come through as a really important aspect. Again, perhaps not so well represented in data. So I could say a lot more about that, but I'm going to move on because I want to talk about how we're now trying to look at this within data. So if you take one of our work themes at the top there, and within that are the concepts, so all of those things that we had around the outside, for example, those sort of finer concept points. We then have a team discussion about how would that be represented within data. For some things, it might be a question of developing actual code lists. For other things, we might have to calculate that concept within the data. If we're developing code lists, we then go to a code list source like Open Code Lists, and a clinician would develop the code list and then go through a clinical verification process and through a a sort of concept pipeline in order to then implement those concepts in SAIL and also in CPRD. So to give you a sort of illustration of that, we take our accumulation and complexity theme. Within that, you've got maybe a couple of ideas. One, accumulating new conditions over time. The second would be having to self-advocate. Now, you can imagine that accumulating new conditions is something that you can calculate from within the data, and that's been done by many studies. And it might be, for example, the count or type of new long-term conditions over time. Having to self-advocate is something that's more difficult to get your head around. And we look at code lists for that. And here, for example, are some codes looked at within the open code system around self-advocacy and that idea of having to self-advocate. And then through the clinical verification process, so that there's at least 2 reviewers have looked at it, and into the coding pipeline, into the concept pipeline. So it's a complex process for all of those concepts we've described. Now, I would like you to take this slide with a big pinch of salt, because this is some very early exploratory work. These are not the features and variables that we're using now, but it's just to illustrate the way in which we're approaching some of the clustering. So you can see within the main SAIL cohort that I described, we've got a sample here of about 60,000 people just to explore the method. We've taken some features and variables there on that top box, and we've undertaken some K-prototype clustering to look at how conditions, what features cluster together, and then we're sort of using the explainable AI methods to explain those clusters. So on the right are some examples of clusters, and again, take this with a big pinch of salt. These are not final clusters by any means, but it might be, for example, if you look at cluster 2 there, it might be that there's a cluster around high frequency of hospital appointments with early age of onset, either very low or very high accrual interval between conditions. So you can see that the cluster is determined by some of those burden ideas, rather than being a cluster of diseases or a cluster driven by the diseases. I hope I've explained that in a way that's reasonably understandable. So the next bit before I hand over to Nisreen is just to say we're also mapping this concept of burden onto the birth cohort data, which is very much a work in process. We've been undertaking team workshops where we take our themes of work and we look at those concepts that we've been developing for the electronic health records, and we have to go through a detailed sort of row by row consideration of the many variables within, say, one particular age sweep of the birth cohort, and agree or disagree attribution to particular work theme or no theme. And there's a really rich mixture of variables captured, as I say, within the birth cohort. So here's some examples on the right hand. So you can imagine the complexity of trying to do that. And later on, what we're hoping to do is to then look at overlaps between the burden expressed within the birth cohorts and the burden, the themes of work expressed within electronic health records. So it's very complex, as I say. I'm going to hand over to Nisreen now to carry on talking about the early life aspects.
Thank you, Simon. So yes, complex is a word that came up a lot so far in terms of what Simon presented. Definitely when we're looking at the early life determinants, using those multiple data sources is quite complex. There is some rich data there, and it's variable between kind of the routine health records and the birth cohorts, which have a lot of this sort of early life determinants at multiple time points for some of them. So what we did to kind of start conceptualizing this, we looked at the literature, we looked at the policy in terms of, because we really want our findings to be implementable and meaningful in terms of practice. So I wanted to know, what is it that people think is modifiable and we can work on, and we'll come to the modifiable bit a bit later. But we then did a kind of a literature review and conceptualization, but we thought, well, that is biased in itself because it doesn't cover everything. It's what people have focused on. So we did a public engagement co-production workshop to understand what are the missing particularly what people think about these domains that we've developed in blue, and what are the missing factors. So we did another conceptualization from these PPI workshop in orange. And then when we put them together, there were 12 domains of early life determinants of multimorbidity based on the literature, based on some policy review, and also on PPIE. So these were our domains, and our challenge was to map them against our data. Next slide, please, Simon. So one of the main things that we kind of thought a lot about is that there is a huge amount of data and variables, and if we want to make our findings meaningful, we want to look at what's modifiable. And actually, there isn't really a set definition of what is a modifiable risk factor is. We couldn't find any. So we thought we really needed some considerations or criteria for what we consider modifiable. So we thought we came up with some of these questions or criteria about, can we measure a modifiable factor? Is there a potential for change? In terms of if we change it, does it have modifiable causes in itself? Is it plausible? And is there any evidence of effect, if you work on these modifiable risk factors? So actually kind of as a side piece, but I think very, very relevant to our work, we conceptualize this thinking in a publication, and I'll put the link in the chat if people are interested, just for others as well to consider, what do we mean by this very common term we use in epidemiology and health research, modifiable, and how can we kind of apply it to the data? Next slide, please. So what we then did is map the three birth cohorts, ACONF, the Aberdeen cohort, so the NCDS and the BCS70. And we tried to kind of reduce the dimension of some of these domains. So you can see a list of the 12 domains here. And this is just to give you a flavor. We did some clustering using principal component analysis to give you a flavor of what kind of what were the main or the most important components in each of the data sets. So as you can see, some of them says not applicable, which means, there wasn't available data around this domain in this data set. And obviously some of them would have different components coming out as important. We've also published this clustering. It is out as a preprint now and under peer review, and I will put the link. But we wanted to kind of cluster that. And so this is amazing work, took a long time, led by our amazing research fellow, Seb Stannard. So next slide, please. And then what we wanted to do is we wanted to have those sort of domains, which is again is a challenging concept in causal inference and epidemiology, to say we're not interested in single risk factors, we're interested in a combination in a domain. And this is very much like what Simon said about the clustering, very much work in progress. In fact, we're already kind of changing the approach to this, but I'm giving you a flavor of this analysis. So we chose this outcome of having obesity plus having hypertension, whether that's measured in the birth cohorts or reported as a diagnosis by participants. And we took this combination, and we this is just a simple figure to look at. How is it, what is the pattern in terms of the percentage of people having that outcome combination by scoring the domain? So you can see it by different 5 domains here. So the scores, usually the higher is the most adverse, adverse factors, if you like, in a domain. And you can see there is a neat pattern there in terms of the percentage of outcomes, to varying degrees by domains. We have changed the approach to this, in that we're trying to be a bit more sophisticated about weighing the components of that score, of the domain score, rather than just having all components equally contribute in a score. I won't go into details of that, but yeah, invite us again next time, and in a year, and maybe we can tell you more about this very interesting approach, again with the involvement of the team here, Rihanna and others in team. So I think that's all I wanted to say, and sorry if we've gone over time. And this is the big team. We can't do anything without them. A massive team across multiple institutions, and I have to say it is a big joy and a really great working experience and learning experience to work with this multidisciplinary team and find these new ways of working together and understanding each other and our approaches. So thank you very much.